Okay, welcome back everyone to the Patient Engagement Virtual Day. My name is Matt Rayner, publisher here at Healthcare Innovation. We are very excited for our next session, which will be a fireside chat conversation. The digital front door, how can increasing security actually lead to less friction and better usability? If you have any questions for our speakers during today's session, please utilize the chat functionality within the Zoom platform. We'll get to as many questions as we possibly can during the next 30 minutes. I would love to now welcome in our managing editor for the first time today, Rajiv Leventhal, who will be our moderator for today's conversation. Rajiv, the virtual floor is yours. Take it away.
Great, thanks, Matt. Really excited to continue along this great day of conversation and educational sessions around patient engagement, trends, and best practices. For those who have been with us since the morning, we've had great discussions on wearables, on patient experiences, digital front doors, the evolution of the end user, what patients have turned into consumers, of course, these days, and how the pandemic has sort of evolved a lot of that. We're really happy to be here right now with an industry leader in this space, Imprivata, and two of their senior leaders, Sean Kelly, who's a chief medical officer, and Aaron Freimark, who's a VP of product management. Before we get into it, I'd just like to have each of you give a really 30, 60-second synopsis of yourself and your role at Imprivata, and then we can get going to some questions and some interesting topics. Sean, why don't you start?
Sure. Thanks, Rajiv. So as mentioned, my name's Sean Kelly. I'm the Chief Medical Officer at Imprivata. I've been with the company almost 10 years, and I head up a whole team of clinical subject matter experts who are either practicing nurses or long time practicing for over 20 or 30 years, and also holding leadership and administrative and operational positions on the hospital side, and either formally trained in clinical informatics or just tech savvy. Our role is really to bridge the gap between the tech and business sides, and having grown up in healthcare, bridging over to the clinical workforce teams on the provider side. And so we go around and make sure, in short, that clinical workflows are optimized. And part of that is juggling this aspect of security and usability at the same point in the topic that we're going to talk about today. Importantly, I happen to be a practicing emergency physician still, so that keeps me honest on the tech side, that I'm out there actually using not only the stuff that we make at Imprivata, but that's out there in general. So I'm pretty familiar with a lot of the pain points in the issue, and right there on the front lines. Over to you, Aaron.
Yeah, thanks, Sean. I'm Aaron Freimark. I'm Vice President of Product Management at Imprivata. And there's a team of really fantastic product management personnel who report to me, who we end up being responsible for half of or so of the suite of products that Imprivata offers, in a lot of different places, in communications, in mobile device management, and in streamlined patient check-in with biometrics. Before Imprivata, I was the founder and ran a company in mobile technology, especially in healthcare, called Ground Control, which was acquired by Imprivata early last year. So very happy to be here joining you.
Great, thanks, Aaron and Sean. I'm excited to get into some of the questions. Starting with the 40,000-foot view, there has been lots of documented reporting and stories around how, of course, the pandemic has spurred a lot of progress in digital health innovation in general. One of those areas is patient experience and patient engagement. How patients are accessing care, how they're getting care, delivered to them, of course. To start, looking at the 40,000-foot view, what are you hearing about Imprivata's clients, about the most important learnings around what their patients are telling them about what they're really looking for when they're looking to access care and get care administered? What has evolved mostly in the last year and a half from the patient experience side, and how is that being digitized? Aaron, why don't we start with you?
Sure. No, we've seen a huge change, right? I mean, there's some little event that happened last year, still going on with COVID, but it fundamentally, I think, changed, and our customers think, changed how patients expect to interact with hospitals. For starters, we have a patient access solution, but it requires touching a surface, and it's we can't ask patients to touch things anymore, right? I mean, it's not transmitted that way as much, but it doesn't matter. It's that sort of thing is not really acceptable, nor should it be in the future, right? With infection control. But as well, there's a lot of other context that's been happening and changing with telehealth, with which a lot of people thought was going to be sort of a short-term thing, but we're all understanding now. No, this is a pretty fundamental change with how healthcare is delivered, right, Sean?
Yeah, I'll speak from direct experience. I think we always knew, and Aaron mentioned the company he ran that Imprivata acquired, Ground Control. We'd always been on a glide path knowing that telehealth and the digitization of healthcare would happen. We figured it would be over the course of another couple of years. And then the pandemic hit and it became much more important, really lit a fire under these use cases. And, the way it played out for us personally was visitation policies in particular at hospitals suddenly got clamped down because justifiably so, we didn't want to have any family members at risk or spreading COVID or other things in between patients and family. And so suddenly you had tragic things going on, like someone was in the ICU and couldn't have a family visitor, or there were babies being born and the dads couldn't go down to the NICU to visit. And hospitals started to get iPads and other iOS and other devices donated to them so they could put devices managed by the enterprise, but given to patients for them to use to actually see their loved ones like this and to Zoom or FaceTime. And that really became an amazing solution that really helped give some humanity and human connection back to patients. And once we started to roll those out and got them into patients' hands, it was realized, this is actually a great way to communicate, not just with family and to use for infotainment, but guess what? Maybe to talk to that nurse outside of the door who you don't want to have to don and doff PPE all the time. And, remember early in the crisis, especially here in the US, that was a precious commodity. It takes time and effort and cost, and then there's risks of contamination. And, my own chair said the best PPE on the planet is telehealth, right? You can't catch something if you're talking through a screen. And so it became an extension of care and a betterment of care. And then it even evolved further. The use case went from the visitation to the nurses and care team talking to that to actual virtual rounding. And man, we should have been doing this all along, right? And, and absolutely the pandemic is a crisis. It was a crisis. It's still going on. But in the ER, we like to joke in the way that we do, never waste a good crisis. A lot of people out there on the hospital side and on the tech side have not wasted this crisis to roll out projects in the matter of a few weeks that normally take months or even years. We have several customers that rolled out on the order of 5,000 devices in a few weeks. That's an incredible explosion of implementation of technology. And it's amazing what we can all do together if we do it and coordinate. And now we're trying to back up and figure out how we manage this and how do we actually account for the security implications of it. And that's part of the discussion today, but that's what jumps to mind first are the patient use cases. I'll turn it back over to you in a second, Aaron, but remember, we've been doing these managed devices and mobile applications for a number of years and not just with patient devices, but for staff devices too. And so, and maybe some of you are familiar with that, but, we hand off these phones between, the 7 to 3 and the 3 to 11 shift for the roving teams like RT, PT, OT, charge nurses and things like that. So I'll back to you, Aaron and Rajiv. That's just the first thing that popped to mind, but there are many.
No, and I imagine a lot of people on the call, we're exactly in this situation. It's like, we got to get iPads out. We got to, get mobile out and rolled out, or we have to find ways to communicate with our patients when they're remote. And, all of the hospital systems I'm familiar with pulled it off in one way or the other really impressively. And so I think, like you're saying, that really showed everybody, okay, well, this was on our roadmap, but we just accelerated everything by 3 years. And, now that we have a taste of it, let's back up and do it a little bit more thoughtfully, more organized, more securely, right, than before.
Yeah, and I think, what in our experience, what happened a lot of times was these devices got out there and you ended up depending on guess who to provision them and get them ready and troubleshoot any IT issues with patients. It falls on the nurses and the unit coordinators and the people on the front lines who have a lot else to do, right? They're trying to care for COVID patients and non-COVID patients in a new environment with all new rules and responsibilities and rotating units and pop-up tents and triages. And, they're literally, putting up plexiglass screens while they're trying to manage how to provision an iPhone. That's not right. And so you really want to leverage good technology and technical partners to be able to roll these things out nice and easy. Banks of phones, you just stick the phone in, it charges up, it lights up, you tap in, it lights up when it's ready, you get it. It's all provisioned. You can hand it to a patient. You can take a staff member, can grab it. It's automatically got all the right stuff on it. It's been wiped clean security-wise from the prior patient. It's all provisioned and ready to go and charged up. It sounds kind of like a simple, small thing, but it can make or break the difference between, letting charge nurses and floor nurses and techs and everybody actually care for the patient and operate at the top of their license. And so, I think it's really incumbent upon the leadership, both on the provider side and the tech side, to make sure everybody gets to do the job that they're trained and they want to do, and let the IT work for them instead of against them.
Yeah, you both made so many great salient points. Mentioning that a lot of these initiatives and roadmaps might have been there in place, but of course quickly, rapidly shifted just as a result, as a forced result of the pandemic. And on the other side of that, the patients their expectations have changed as a result of the last year. What they think about hospitals and health systems have changed. And, that's going to be an interesting dynamic as hospitals and health systems continue to kind of meet that new demand. And one of the issues there is, you guys touched on it, is security. As patients, are going to want to make sure that, their data, as life becomes much more digital in the medical world, that their data, remains as secure as possible. Is it, how does that landscape look like to you guys, looking at, with the proliferation of digital all over healthcare, devices and data, security is a concern. What are ways to kind of ensure, at least in the best way possible, frictionless patient engagement while also remaining secure? Is that a little bit of a too high in the sky concept?
No, well, no, I don't think it is. I think it's very attainable. With this last year and a half has seen really it existed beforehand, but it's really in the consciousness now, and we're seeing way too frequently ransomware attacks on hospitals. It's really a case of beating someone when they're down in a bad way. But it's also, more from the patient's point of view as well. This is the time where so many Americans were hit with unemployment fraud, right? I mean, with being able to have somebody else register in my name and get these checks. This has happened to two of my neighbors, for example. And I think we're going to start seeing much more sensitivity on the part of our patients to guard their privacy, because any of that data can really leak out and have a very big direct effect on me, right? What I mean by that is, one of my neighbors was unfortunate and lost her job and applied for unemployment, and the unemployment authority says you can't apply for unemployment because you're already receiving unemployment. And then obviously it wasn't her, it was somebody else who did it in her name. So the fact that when a patient registers, we ask them for so much identifying information. Whenever somebody shows up at a hospital, right, we ask them for all the information they need in order for somebody else to commit fraud. It's not that they don't trust us, it's that they're going to start being reluctant to communicate that information verbally to communicate in a way that somebody can be listening to it or writing it down, communicating in a way that somebody can be, looking over your shoulder at something, and really wanting to interact with the hospital with a more secure communication and tunnel, right? I mean, when we're talking to our banks, we don't tell them our social security number or our birth date out loud, right? That hasn't been the practice in I don't know how long. There's other ways to communicate. And I think that's what's going to be the expectation among healthcare consumers.
It's interesting. Something simple as, what is your birthday? What is your social? What is, this, demographic information, whatever. That really shouldn't even be said out loud, spoken, even at that process. That's really interesting. Sean, any thoughts?
Yeah, this is a particular passion of mine. I traditionally, there's been this thought that you can either have security and compliance with regulations and privacy, or you get like usability, efficiency, and productivity. You can't have both. You got to choose, right? Either lock that stuff down or you open it up and you let someone in. I think that's absolutely incorrect. I think actually we should all demand, and now consumers are starting to demand, that better security can actually be more usable, right? More efficient and and higher productivity actually can come with a solution that is safer and compliant. And it's just a matter of like getting into the details of that technology. And some of that can, be like using advanced technology like biometrics. And so there are obviously some issues with that, and we can talk about that, and some hesitancy, but combining different technologies like biometrics and something you might know, or a couple different methods of authentication or adaptive authentication, where if it recognizes you or your device, then you can back off on some of that, the security barriers, versus if something unrecognizable or suspicious is happening, if suddenly I'm trying to log in, not only from here, but also from China or Iran at the same time, well, then the system can ratchet it up. And so smarter technology can help us achieve this. In fact, it's already working today. There are lots and lots of examples that we provide and others provide that are actually brilliant examples of, hey, this is safer, it's more compliant, and it's actually easier to use. With our DEA compliant technology for electronic prescribing of controlled substances, in some cases we can leverage low energy Bluetooth. It creates a handshake. I've already credentialed my phone. I've authenticated into the system as a provider, and the DEA accepts as one of those systems. It can call out to my phone through low energy Bluetooth, generate a PIN and send it back faster than I can even acknowledge it happened. We have to tell the provider that it happened. It's so easy. And that's the highest level of security you can get, is a DEA compliant system. And then we can leverage that same system of proximity awareness and low energy Bluetooth to do a secure walkaway function, so that while I'm talking to you at this computer, if it senses my phone's here, we can back off on security settings. It allows me to interact with the computer. Even if I'm over here, administering medication to a patient, the screen can lock. It can be all secure. If I come back and it senses my phone come back, it opens right up. I'm right back in. It's easy as can be. It's more secure and more compliant and easier to use. But if I forget to log out and walk away, we can shut that session down because we see the signal strength go away, the accelerometer move, and the behavior changes. And so it's all about the technology. Good technology can actually give us more of both.
Even just smart technology, right? I mean, the classic example in my mind is the Imprivata badge tap for clinicians. It's just, okay, I just tap my badge and I'm in the system. Maybe I need a PIN. But what that allows is a 30-character Active Directory password that's rotated frequently, right? It allows the external access to be hardened because the internal daily access is so easy and trivial to use, but the person's on site. It's very proximity based, right? And so when you're inside, you have one method. When you're outside, you have another method, and you can harden the outside external access. That's really been the risk for so many places. Now, what if we had a similar sort of method of access, similar to the badge tap, but for patients, right? If patients, no, we're not going to give them ID cards, but if patients have ID cards already, it's their palm is an ID, right? And they can access the same sort of thing when we know who they are. We have high assurance with just their palm, or even maybe in the future a tap of their phone on there instead of an ID card, and have all of that secure, high assurance knowledge of who that person is without having to say who I am, what my birth date is, et cetera, out loud. It's all trusted, and it allows us to harden the outside, because when they're there, we have all of that data, and it's very slick for them.
Yeah, so you guys both made great points about why the advantages, of course, are there, right, for using these approaches. Sean, you made a good point. You were saying you don't have to choose one or the other. It's not a sacrifice to choose one and forego the other. However, there is a sentiment that there is still significant risk, security risk, in collecting and maintaining biometric data. What would you say to that when you think about maybe some believe that it does provide an increased risk surface?
Yeah, I think the devil's in the details, right? So I guess think about it this way. The status quo right now, like Aaron said, oftentimes I might walk up to register and literally say my social security number out loud, turn over my license, say my date of birth, all sorts of security risks right there, probably more so than if I walked up and, we happen to use several different methods in several different areas, but for patients, the most popular has been a palm vein scanner. And you walk up and you put your palm on now a touchless scanner, as Aaron mentioned, and it sees the vein pattern beneath your palm. It's an infrared scanner that reads it, just like a pulse ox machine or a TV remote. Requires my live palm to be there. So there's no forensic value. The criminal justice system don't follow it because I can't leave my live palm at the scene of a crime, right? It's not like something I can leave somewhere.
Well, you're an ER doctor, so you might have seen that before.
Right,
I'm not sure.
right. Yeah, well, yeah, that's a different story for a different webinar. But anyhow, it's ideal for actually matching a human being who's present to a data set. And there are many protections around that people may not understand. And so I think part of the issue is just change management and culture and education. But no image of my palm vein is ever stored. It's a hash. It's a bunch of ones and zeros that is, that maps to my palm vein image that's logged into a system that, oh, by the way, is held by the provider system, not shared with the vendor or held universally, and it's encrypted. And so the only way really to match to it is to have someone's palm come up that looks exactly like it. And it's incredibly accurate. The false positive rate is less than 1 in 10 million. It's virtually 100%. And so the value of that far outweighs the risks in my mind. And so I'm brainwashed as an ER doctor to always look at things in terms of risk versus benefit. So the risk of doing things the way we do it now compared to the benefit of it, of walking up and all the different human factors that can come in. If I'm in extremis and I walk into an ER, never mind if I speak the same language, I'm not having a stroke or dizzy or intoxicated or have a language barrier or hard of hearing, if I can even communicate well, even if that registrar gets the information properly from me, there's still data entry issues. There's chances for mistake or intentional fraud, or someone behind me shoulder surfing and stealing my identity. So like the risks of how we do it now are crazy bad versus you walk up and don't reveal any of that and you put your palm down and it recognizes you and matches you instantly, virtually 100%. So yes, there are concerns. I think it's a matter of actually looking at the data and looking at the use cases to sort out what the real risks are compared to the real benefits. Because to me, it's just, far
And
away.
looking at like the company that's providing the service, right? I mean, and what are they getting out of it? Like with the palm veins, our company, we're interested in providing a service. We're not interested in collecting anybody's biometrics. We don't have access to that. That's in a hospital, that stays in the hospital. We never see that, right? We don't have some cloud where we're collecting all of that stuff and using it for nefarious purposes or advertising or anything. That's not our business model. That is the business model for some companies. And it's good to, when you're looking at vendors, to to kind of poke at that a bit, right? And find out where that is. I think there's the regulations that exist in a number of states are, are well designed to protect you, because these are identifying information, and we don't really want to be having those passed from company to company or person to person. And like you said, Sean, it's stored as a hash. That's a one-way trip, right? You can make sure this matches, but you can't use it to regenerate a palm anywhere else. It just technologically, it just doesn't work because it's a one-way trip.
One question here from attendees, and feel free to keep sending them in until the top of the hour. Going back to our couple original questions, not related to security, there are commercial services like Teladoc and Amazon and others which offer sophisticated services that are booming. Knowing that, what kind of are the determining criteria to think about insourcing versus outsourcing to use both in-house and commercial best practices? Any thoughts there?
Yeah, I'll kick it off. So I'm biased, obviously, towards clinical workflows. I think that the healthcare side, the provider side, healthcare delivery organizations have a ton of talent, IT talent, IS talent, informatics, clinical operations, and they should use that talent for things that they know the best. So, if something's commercially available, I favor using that, but then using your people to link it together to the use cases the best way possible. You understand what your patients need and what your staff needs better than a commercial entity. So why spend time and effort doing things that a good vendor can do with you and for you, but then spend your time and effort doing the integrations and, making that system really communicate well with either your own home built stuff or, your EHR or your patient registration system or whatever the case may be. And so for me, it's more about the higher level integrations and architecture and guidance is where the IT talent on the provider side should be. And we have customers, everything from small critical care hospitals and offices up to the major academic centers in the world and the largest, commercial entities out there in healthcare. An incredible talent pool, but you don't want those folks doing fixing the plumbing. Let them do the fancy stuff. Build the fanciest toilet you can or the fanciest sink you have. Let the vendors take care of some of the infrastructure underneath, is my opinion. But I don't know, Aaron, if you have thoughts.
No, I don't really have anything to add to that. I think it's true. I mean, what's amazing to me is somebody who's spent, the last 5 years increasingly in healthcare, but a lot of it outside of the industry is how dissimilar one hospital system can be to the next, right? Even of the same size. And Sean, you'll just know this a lot better than me, but it's there's no one size fits all here ever. And they can have similar desires and needs and have similar solutions, but when it comes down to the details, there's such difference in what their staff needs, what their culture is, how it has to be tuned to that particular use case. No.
Yeah, that's great. Let's finish with one kind of closing thought from each of you. If you think about, everything we've talked about, the proliferation of digitized services around enhancing patient access and patient experience, the security implications and considerations around that. What do you think is most important that could be applied to a post-pandemic world, looking maybe in the next 12 to 24 months down the road? I'd like to get, one closing thought from each of you, Aaron and Sean.
Sure. You want to go, Aaron?
No, go first.
So, Rajiv, Aaron and I have talked about this. Do you telebank?
I do.
Yeah, it's like, what does that even mean, right?
Right. You just say bank.
Yeah, you bank. I bank, and now it's mostly digital. Like it used to be, I went in. I'm old enough. I actually went into a bank. I darkened the doors of a bank, and then I used to just go to the ATM most of the time, and every once in a while I'd go in the bank. I tried to go in the bank the other day. They sent me out to the ATM. right? And then just like get back online, right? So it's almost all digital. It's been, completely digitalized, and there's been an evolution. And I asked, I've been asked the same thing around telemedicine. What is telemedicine? We shouldn't think of medicine here and telemedicine here. It's all healthcare. Some of it can be digital, some of it's in person. Obviously, you can't put stitches in remotely yet. So a lot more of healthcare may stay in person, but in general, we're gravitating to more and more digital care delivery. And so there will be this gradual evolution. Consumers are getting accustomed to it in their world outside of healthcare. They're walking in the doors with iPhones and iPads and everything else, and Androids. So it's a wave that is upon us. We need to adapt or not survive. But I see it going to more of a blended world where it's becoming more and more natural to just think about healthcare as mostly digital.
Yeah, a lot of telehealth advocates have told me that, the holy grail is, virtual care just becoming care. Aaron, any quick closing thoughts?
Yeah, no, exactly the same thing. I think it's incumbent upon us as healthcare providers and the technology solutions to help them to start thinking about healthcare the way that our patients already think about it, right? They want to do this remotely. They don't want to drip to the hospital. They don't want to wait in a waiting room anymore. They don't have this idea of physical presence, because healthcare is really one of the last ways that they interact with any service that really demands something on presence. And there's a huge value to doing that well, like we've done it for a long time, but this is the way that our patients are already thinking about it, and it's time for us to get on board too.
Yeah, it's a good way to close. Thanks so much to Sean and Aaron from Imprivata. It was a great talk on patient experience and access, and of course the really important security implications and considerations there. We've got one more session, and to tee it up and preview the rest of the afternoon, back to Matt Rayner, our publisher.
Thank you, Rajiv. Thank you, Sean and Aaron and the entire Imprivata team for your support of this program. As Rajiv mentioned, we've got one more session for this patient engagement virtual day. So we're going to first have a very quick, one final 30-minute break before that session. So feel free to stretch those legs, reply to some emails, anything you need to do, and then get back here promptly at 4:30 p.m. Eastern time for our final discussion, which will be on patient engagement strategies for the hybrid care paradigm. So that will be at 4:30, and we will see you all then. Thank you so much.